Okay, so we can start it. So hello.
Yes, sir. We are live now.
Yeah. So hello. Good morning, good afternoon, and good evening to all our distinguished speakers, chairs, and audiences of ACNS YNS webinar from different part of the world. Today we have yet another session of educational lectures for you to promote the neurosurgery education in the low resource country, and this episode is to encourage the education in Afghanistan and Latin America and Caribbean countries. Today we have our last webinar of this year, and this falls exactly on the Christmas Eve. So today we have our invited expert speakers, Professor Irion K. Musabilu, who's from Toronto, Canada, and is going to talk about traumatic brain injury and its management and some part about the history of traumatic brain injury. And our next second speaker will be Professor Naoya Uwayama, who's an expert endovascular neurosurgeon from Japan and who's going to talk about flow diverter treatment of the cerebral aneurysm. And at the end, we'll have an interesting case discussion about the complications of ventriculoperitoneal shunt by a young neurosurgeon from Afghanistan, Dr. Khyber Iqbal Safi. Along with that, we have our chief patron, Professor Yoko Kato, and our co-patrons, Professor Fawad Pirzad and Professor Federico Saleh. Professor Federico is the president of Uruguayan Society of Neurological Surgery, and Professor Fawad Pirzad is the president of Neurosurgical Society of Afghanistan. And on behalf of ACNS YNS Committee and Professor Yoko Kato, we welcome all the speakers and audiences to this educational online platform of ACNS YNS webinar. And to moderate this session, I have Dr. Win Yi from Myanmar, Dr. Rihanna from Afghanistan, and Dr. Chen Chuya from China. And along with me, I have my all-time partner, Dr. Liu, as co-host. So with that small introduction, I would request our chief patron, our president, ACNS, Professor Yoko Kato, to say some opening words, please, Professor.
Thank you very much for joining this year, the last YNS the webinar. So we focused on the YNS education. It was very successful with Dr. Sachin and Dr. Liu and some other great efforts. Thank you so much. So today I'm very much looking for the three very nice lectures. So maybe I think Dr. Federico, thank you very much for sharing the session. So what time is Uruguay now?
Hello, thank you for your invitation. It's pretty early here. It's 7:30 in the morning. So I'm also looking forward to listening to this interesting topic.
And thank you very much for the three female neurosurgeon from Myanmar, and also Afghanistan, and also China, Shanghai, and one more from, of course, Dr. Sachin. So maybe we'll have a very nice the educational webinar. Now let's start. Thank you so much.
So without any delay, we will start our webinar, and our first speaker is Professor Irion K. Musabilu, who is originally from Albania, but he is currently practicing in the University of Toronto, Canada, as a chief neurosurgeon there. And he is also a fellow of Fujita Health University with Professor Yoko Kato. And he's going to talk about traumatic brain injuries management and a little bit about the history of traumatic brain injury aspects. So may I request Professor please to share his screen and start the presentation.
Are we good technically? So my screen is coming up. Is that okay now? Sachin, can you confirm with me? Can you see my screen from your end?
Yes.
Yes, perfect.
That's wonderful.
Yes, Professor, we're able to see you. Good to go.
It's so wonderful to join you guys. This is the last session. I never thought I would make it, but thank you so very much. To start with a few disclosures and make some corrections. Yes, I'm one of fellows of Fujita, and I'm currently living in Canada, but my direct affiliation is only academic to the University of Toronto. I'm not practicing in Canada, and I'm trying hard this time around to get to practice in US. So this is the time of the year that I'm working to get there. That is very important to say. I put together some slides. I'm very happy, and thank you very much to all of you for having me here today. But I want to make one special note. I have every single slide most likely sourced out, but there are a couple of slides that come out of my experience, and it's a word of caution when you try to use those in your own practice. My understanding of traumatic brain injury comes with the country, with the region, and since this is the last session and it is dedicated to the work of neurosurgeon in Afghanistan and in Myanmar, it came out to my attention just about 1 or 2 weeks ago when through a symposium organized from the Miami Neurosurgery, Professor Mohammed Aziz Ali Sultan, originally from Afghanistan, was speaking about his work in conjunction with the help of Professor Yoko Kato to promote education in Afghanistan. So I find it very humbling to be here with you today, guys. Thank you so very much. And without delay, let's start. This is going to be our topic. Is this I have a second screen. Is it coming on your way? Should I minimize this? Are we good now? Is this better? What I see is clear on your end. Sachin, can you please confirm it with me?
Yes, we can see the screen. Definition, causes, types, epidemiology.
Perfect. Thank you so very much. Okay, let's move on then. It has always been a major topic in neurosurgery, neurosurgical focus dedicated the whole volume in 2019. Before that and after that still remains a topic of interest. How would we define? I've been thinking hard this time around, and the only way I would come with something that stays clear, it's following a trauma, there is a disruption of the way brain works and the brain function. I've seen cases of many different variants of any trauma possible during a year of practice. I had at the only level 1 trauma center in Albania when I was practicing there. But throughout that time, the only lighthouse and the guiding principle for treatment were the anatomy basics. And I used that throughout my practice. Other than that, 2 cases are never the same. What are the causes? It differs the way you classify it, but I have come up to this classification, which I find it very practical. You have one-time trauma irrelevant of the outcome, and you have repeated trauma. I'll come up with something out there very soon. Is that relevant, the mechanism of trauma? It does. The mechanism of trauma reflects the outcome, the way we treat, and the recovery period of any patients we have seen. When I mentioned is that the repeated trauma in 2006, Professor Amadu, then practicing as a neuropathologist at the University of Pittsburgh, came up with this wonderful paper, what we now know as a chronic traumatic encephalopathy. And this is what comes out of repeated trauma. Slides showing amyloid plaques entangling, and then this PCR of DNA from the pathology samples extracted from patients following chronic trauma. At that time, football players in the NHL league in US. This is definition added to what we knew up to 2006 regarding with trauma. We clinically divide those in 3 main categories. It's called mild, but then moderate and severe usually are clustered together. The only reason is that clinically the mild one is non-life-threatening, but moderate and severe can fall into the life-threatening category, irrelevant of the way we treat patients most of the time. are different reasons for, and the falls, firearm-related injuries, and motor vehicle accidents are the main ones in US. When I'm saying US, most of the reference that I've been using comes from the CDC, which is the Center for Disease Control in US. And for the elderly population in US, which the numbers are growing and above 75 years old, falls are the main reason. When I specify to US, I want to make a clear statement that comes out of my experience in trauma. Not two countries have the same reasons of their traumatic patients, and not two regions have the same. So how do we structure and regarding the classification? It's what we see that's visible, and it's only non-visible is the other one. Although we have a trauma, there is not much we can find out of the imaging. When we say visible, it's visible. You see trauma on the outside, or there is a trauma visible diagnosed through imaging. There are very, regarding to the types of injury and the sequela that's developed from a traumatic brain injury, two types have been coming out, and I would state out that comes from the double Acns. When we have a mass lesion, and that was going to produce an increased intracranial abrasion, either relevant if that's coming from the hematoma or direct contusion to the brain matter, or subdural or subarachnoid hematoma. Now, injuries do not always relate to the effect of a mass. We should always point out to the diffuse injuries, those being microscopic or diffuse axonal injuries. Later we see as the edema. The epidemiology, it's always country and region dependent. For example, in US alone, there are about 200 deaths daily. That's not the case in other countries. It is more common to males, about 2 times, and those are the ones that more often are hospitalized. It is also the males 3 times more likely to die following a traumatic event. In US, the numbers are a bit tipping over the edge as the numbers of the elderly increase, and this is about the 75 years old, where we have the highest numbers and rates of TBI-related hospitalizations and deaths. Well, falls is number 1. About 50% are related to falls in US, and that because the most numbers are related to either the elderly population or the younger ones. Firearm-related suicide are the most common cause of death related to the traumatic brain injuries in US, but that not necessarily in other cases. And since I see in the panel we have guests and faculty joining us from Peru and as well from other regions, I would very much be interested what are common causes of death or traumatic brain injuries related following trauma in their countries. However, worldwide, this is a recent report of published at the World Neurosurgery. Neurotrauma surgery covers about 40% of neurosurgical procedures, which is a very large volume. And across the globe, there are more than 60% of us involved in treating traumatic brain injuries, those commonly so in developing areas. So, as I mentioned, over 50% of traumatic brain injuries are related to falls. There is a clear cut in Northern America, and that includes United States and Canada. 5 years and older motor vehicle crashes are the most common causes of traumatic brain injury related deaths. But if 5 years and younger, assaults, direct trauma and abuse to children is the number 1 cause traumatic brain injury related death in Northern America. And I'm not sure this is the case in other countries, but I do believe differences exist in most of the countries in the world. As it comes to some figures which speak volume, that's about 1.7 million people that sustain traumatic brain injury annually in US. More common cases, about 75% are those that are mild. If we were to put it into numbers and bring those heads, the numbers are staggering because they cost billions of dollars either to diagnosis and treatment and the follow-up and recovery to the United States healthcare. So what is it? I mentioned about over half of the populations that follow, it's because of the falls. unintentional brain trauma is very common to children. It's about a quarter of those cases. And assault is more common in younger kids, which is usually younger than 5 years of age. And I need to specify that that's typically North America, which is US, Canada included. So if that comes to epidemiology here in our region, minorities are those that make the bulk. They're service members, which is serving or veterans, and those who suffer homelessness are as well making up a bulk of the numbers. Yes, there are cases of correctional detention facilities, but this is not the majority. Partner violence is a major issue, and that makes a good percentage of all trauma-related cases. And in rural areas, cases are increasing. So if we speak about clinic, we have to relate it to pathology. I mentioned not two cases of trauma are the same. The symptoms are generalized, but everything relates to pathology. That part of the brain matter, either directly or indirectly affected, would give us the clinic. And that's the way we diagnose, and that's the way we follow up any progressive deterioration during treatment as we have assessed the patients. Danger signs, these are very relevant and differ very much so in the adult population and in children. And we have now groups of interest that do gather together in annual or biannually to see and reevaluate the protocols as we go through trauma protocols differently in adults and in children. If we come about anything relevant in the history of neurosurgery, history of trauma has been there with humanity from early days. And when I could talk about history and if that comes to diagnosis, I wanted to point out a couple of relevant milestones in the history of medicine. In 1972, Dr. Hansfield, a scientist, came up with the idea, this is the first commercialized scanner. The reason I say 1972 is that not long after that, Dr. Jonathan Teasdale came up with a Glasgow Coma Scale. And what did we do before that? We used clinics. And we still do. It was long after that, 1980, that we started to have a general idea of the commercialized first MRI. It came out of Scotland, that machine that's doing wonderful work to diagnose not only traumatic brain injuries following trauma. So what we do for adults when we suspect a traumatic brain injury, in this case, I need to point either that being mild or moderate, we do assess, we do evaluate, and we do follow up. The reason I'm mentioning that is now recent protocols we have, and we continue to avoid use of CT scans. MRI is never the first diagnostic tool to being used in any emergency department in North America. And it comes with a lot of cost. And the reason I said it's the follow-up in the clinic is because we try to avoid the CT scan to diagnose the patient unless necessarily needed. When it comes to the history and the treatment, that's a multi-phase process, and it has been so for ages. About 1,000 of years, that was before Christ, we came to find out, and that was only in recent years, but we came to find out that there was a papyrus, it was a written work of cases and how to treat surgical cases, including cranial trauma. So it speaks that it has been with us, and the history shows that this work has been for ages with humanity. In a wonderful paper came out of Lancet, treatment procedures were not that outdated. So we used cautery even before we had the perfect instrumentation of cautery, and that was done to treat traumatic cases and in different ages. Procedures irrelevant of the region in the world hasn't been much different as it's shown. This was another wonderful paper showing, for example, during the Iron Age, how throat fanning of the skull was used to treat traumatic patients. This is on the left. And then a crinoplasty. Crinoplasty coming during the Inca Empire. A fellow colleague coming out of Latin America might have come with more resources for us to share. And this is in the 18th century French. Trepanning was here with us treating traumatic brain injuries earlier than what we know. These are findings coming out of a later period. not dating to the Edwin's papyrus, but relevant images came out of the Edwin's papyrus showing the work was done way earlier of how we know of treatment brain injuries. Instrumentation has changed, but the physics and the mechanisms remain the same. When I say the physics and mechanism remain the same, this is a 15th century Italy drawing of Dr. Berengario, and he's a famous Italian surgeon coming out of family of barbers, hair cutters, as if it is today, who is one of the physicians who treated Lorenzo de' Medici, a very famous figure of Italian Renaissance. Following that period, many other findings came to be to the light of publications. I just wanted to depict this paper published about 2 years ago in World Neurosurgery, showing how from late 15th century development of crinoplasty came to the light of humanity. And why do I mention crinoplasty? It has been a way of debate when we come to treatment of using cranial decompression by via of craniectomy, and how to treat and possess technical notes to then to conduct crinoplasty later when needed. Actually, it has been done quite well with very good results from late 16th century. We knew that trauma kills you, and this is UL killing General Cicero during. This is a painting of Lambert Lombard showing how that was done during the Roman Empire temple hit. Well, what it is today. Today, protocols change, and that varies with countries, but that's what it is in North America. You are dispatched after a call, and a center of reference is addressed, whether that's in a rural or a center of reference trauma in a major city. This is the protocol we follow today in US. This is generalized and practice of care. What we do, we assess before the patient has arrived to the hospital. And I need to point out something. We have colleagues here that practice in Japan, but we have colleagues as well that practice in smaller countries or countries with fallbacks in development of neurosurgery. And what I want to mean is that the emergency teams in North America do assess the patient before they arrive in the hospital, and they made a sound judgment of where to direct the patient. For example, in New York, there are many medical centers and trauma centers from level 1 to those of lesser importance, but that does not mean that any center will be dispatched a traumatic brain injury. What we do in general, that starts with the emergency team on the field, on the route and on the ground before they arrive to the hospital. They assess, is this a minor and it just needs reevaluation and discharge, or this is a severe case or a moderate case. Moderate severe cases go to designated trauma centers that do treat patients with traumatic brain injuries, but that's not the case in minor injuries when it requires follow-ups that not necessarily are sent to traumatic brain injuries centers. Recent protocols, and this is a 2019 of the World Journal of Emergency Surgeries. During their Congress in 2019, they come out with this protocol. It is wonderful. That's what we use, and we rely much on in the help of our emergency physicians in the emergency department and rooms before neurosurgeons get to see a patient. Is that bleeding, and that two different outcomes out of it? And does that the patient requires surgery? These are important steps in the algorithm of treatment and patient. That's how we proceed in North America. This is standard of care. ICP monitoring, either that being invasive or not. When I say non-invasive, now we have a non-invasive measure, a way to measure cranial pressure. Has been a way of debate, but there is a class 3 evidence that ICP monitoring can be used throughout admission and periods of post-treatment when it comes to surgical cases with very, very good results to evaluate changes into pressure within the cranium. This is the Red Journal publication of 2017, the 14th editions, and it lays out very nicely all from level 1 to level 3 evidence of care into traumatic brain injuries, and that follow all the steps that we need. And that's how we do follow patients of traumatic brain injury in North America. I put out the slides, but for your best interest, I would recommend you to read the article. It's not that voluminous, but the tables need to go through very carefully on individual slides other than on the PowerPoint presentations. This is a work that we published early with Professor Kata. This is work coming out of Fujita, and back then we were trying to deal with decompression regarding the malignant vascular stroke. As we were working, we realized that the role of decompression is very important. It has been much debated in early days, but we find decompression to be a very successful treatment procedure once decided that you have to perform a decompressive craniectomy. We realized that removing the bone, although much more so necessary, it was the dura that held so much pressure under the brain. So a large durotomy was required. This graph here on the far left shows you the difference in between having the removal of the bone and then when you perform the durotomy. Measurements of size related to the size and shape of the skull were done, and even showing to what extent you have to perform your craniotomy, to what extent you need to make the skin incisions, and how you should perform the durotomy. Is it used in every center? Not necessarily. Have we recommended it? It depends on the guidelines of the country. In North America, decompression is often used. And when it comes to plasty, that's another paper we published with Professor Kata. I need to point out that timing of crinoplasty can be identified through changes in follow-up MRI at about 1 month following decompression, if we were to be correct. I know that there are papers out there that show you that in between 2 weeks to 4 weeks after surgery, you can consider performing the crinoplasty, but that's not necessarily the case in every patient that we have seen. I wanted to point out 2 recent papers, that necessarily the papers that relate us to traumatic brain injury, but as we come now to the genome era of any associated studies, as we have done genome and transcriptome-wide association studies, and this is an area of interest because a part of my work goes to the research of metastatic brain tumors. I've seen that many patients have different outcomes following treatment, and even the time of the diagnosis. What that means, there are now considerations that different protocols should be considered when it comes to the treatment and then follow up at the patient of your region. What I mean by that is, although we have a standard protocol of care in North America, that not necessarily applies to all our patients in North America, and that goes to the immigrant populations. They come out with background of different gene clusters throughout their lifetime, which might be different to the region that you're currently in. I want to point out this for colleagues that might consider traveling and practicing in other areas rather than their country of origin. Not 2 patients are the same, and it is in our genes the differences. Well, pediatric population is very special. It has always been like that, and the level of evidence varies from 2 to 3 in the way we treat, in the way we diagnose at the very first steps, and the way we follow them. Those are papers that not necessarily relate to neurosurgical practice, but this is how we treat in intensive care, in a neuro-intensive care unit. What we do, protocols are standard in North America. This is a separate protocol, and that's in pediatrics. I need to point out not necessarily all protocols relate in between adults and pediatrics, and there are steps that differ in between the two. The red highlighted parts of this slide are very important to have to remember. Does the patient need surgery? Is a candidate to surgery? And if not, what do we indicate to follow up? If a surgery indicated, what are the surgical interventions that we need to follow and in and before the surgery? The pediatric population comes with a special attention because it's making up a great percentage of what we see in North America. I pointed out that before the age of 5 and after the age of 5, mechanisms of trauma differ. However, we have come out to some modalities and protocols to follow when we come to consideration of treating pediatric patients. Is it an acute case, is it post-acute case, or a chronic case? When I mention chronic case, this is a repeated abuse. Most likely cases of abuse fall into the category of following these patients and the protocol laid here. So what are the key recommendations from the Center for Disease Controls when it comes to the United States? This is the center of reference. There is no routine imaging. The reason I pointed out is because not once, but in several cases, there has been law cases sue again physicians and hospitals and special clinics for the reason that they have been taking a patient to diagnostic using a CT scan, considering the CT scan uses ionized radiation. That might be a case of side effects. So no routine imaging, it has been a standard of care now, and that's how it goes on. Do we use it in every single case? Not necessarily. We use cautious judgment. Is the clinic to tell us what we do? To prevent and to reduce the risk in traumatic brain injuries in children, it comes with age. This population here is the one that's suffering the most. The developmental challenge is that they under the age of 5, because that falls under the care of the parent or a guardian or the care in this population. In specific cases, that's only in the North America. I need to specify that. What are the potential effects of moderate to severe traumatic brain injury? I clustered moderate to severe traumatic brain injury for a very simple reason. In today's standards of care, those are what we consider potential life-threatening injuries. They fall in the same cluster, and they have these potential side effects that do occur in the long-term follow-up of these patients. Those have both short and long-term effects in the way we treat and the way we try to help in the recovery of these patients. Now, those are not generalized rules, and we do not recommend to follow the guidelines for every single patient. What we do recommend is follow clinical judgment as it goes to your country, to your region. That should be the way more sounded to follow. What we see in North America, that's the long-term negative effects of traumatic brain injury, because it comes with cost, and the healthcare have to come out with bills to tell us that how much does it cost. It costs a lot. The reasons for this is because it's 50 times more likely to suffer from seizures in patients following traumatic brain injury. They are prone to more drug prescribed to those kind of to this group of populations, and they fall into a category that suffer more from infections, more prone to infections. Actually, about 10 times more likely. 10 times more likely they are also as well to suffer in other areas, and that includes pneumonia, infections of the upper respiratory tract. But what we have seen, and this is something that I need to point out, they have seen numbers that are very staggering, about 9 years shortening in their life. And then when it comes to quality of life, this is something very important, getting relevant in every part of the globe. The recovery and the management, it is the standard. There are groups that do follow up after the surgical treatment. Patients are usually sent, and this is the category of moderate to severe cases when they follow up to the category of recovery. In follow-up, and when it's necessary, follow-up from the clinic, usually it goes with imaging and neurophysiological tests. But what we do recommend, and this is irrelevant of the country of where we are practicing, we need to screen for depression. Post-traumatic stress disorders, the two main common mental health disorders that follow patients with traumatic brain injuries, either that one-time trauma or repeated trauma in cases of abuse. We see other mental health related complications, but depression, post-traumatic ones are the most common. Why do I point this to what? Because the follow-up and recovery period are very costly in the United States and in Canada, and these are always built. When we come to money, then we are always specific. And when it comes to the healthcare of the patient, we need to point out what we need to address as we go through the care. What is the 5-year outcome of persons with traumatic brain injury? This is a data set coming from the Center for Disease Control. And numbers are frightening. If about a quarter die, that's not okay. And if about 30% became worse or deteriorated, that is still not okay. Do we need to do better? Yes, and we have always been trying. And there are groups of interest now that do practice, subspecialize in neurocritical care, and they treat specifically patients that come out of traumatic brain injuries. Out of those, about a quarter either improve or stay home. And when we say stay home, there is another set of team of health-related care workers that have to follow up with these patients, and that comes with cost. Can we do better? Most likely, yes. I do believe so, but necessarily not now. I hope in the very near future that will be the case. When it comes to recovery, it still comes out of the first traumatic. What was the pathology, and it's always clinical dependent. What I mean by that is, I read recently a paper published in the Journal of Neurosurgery. They were studying what would be the outcome of patients suffering subdural hematoma in general when they have a traumatic brain injury. It was seen that the outcome was worse. Was it relevant? Even a minor subdural hematoma, considering involume, had a worse outcome in general when it was only without it. What do I mean, and what do I point out is that the pathology is relevant. Pathology is always relevant to tell us how are we going to try to treat the patient in the first place and what we expect in long-time recovery. When it comes to treating your patients, you have to always be careful when it comes to the admission, which usually are informed in North America, not necessarily where you are to practice, what the patient's medical history is before treatment. And what do I point out and highlight in red is the patients in anticoagulant or antiplatelet medication. It's very, very important when it comes to traumatic brain injuries, because bleeding is a major cause of death following traumatic brain injury. I have two cases. This is a case that has always followed me, and this was at a period of my early days of practice at the National Trauma Center when I was back home in Albania. The reason I remember this case, as you can see, is a shattering fracture of the base coming out of arm, traumatic brain injury following a suicide attempt. We managed, we had a wonderful team taking care of the patient, a very young lady who was complicated with a MRSA infection. To come out to succeed in treating a traumatic brain injury, a severe traumatic brain injury in a patient that this is a projectile aneurysm. It happens, it is not common, but I've seen a few other cases when following a case of suicide in and near the head and neck, you would see aneurysm developing even in younger patients, but belongs the patient to MRSA. Irrelevant of what we tried, the MRSA was resistant to what we had at that time to treat the patient, and I'm very unfortunate to have had to see that case because I suffered somehow along with the patient. This is another case, about 8 centimeter long knife, part of a knife that was broken during an assault in the skull of a patient. What surprised me is that what deficits the patient had before the surgery remained after the surgery, but it goes to show, and this is about 10 years old case, it goes to show that the brain has its own resilience. And if we manage somehow to treat what it is important during the first, to provide the first steps of care, not necessarily all our patients, but some of them do well. And these are the extreme cases that I've seen. I know very well I've seen other cases of extreme, but it did not take much of us to take that part of the embedded knife in the brain of our patient, but I realized that we are going to be surprised at what we are going to see in a trauma setting. Now, I mentioned out earlier that I had prepared some slides where I included Professor Juha, as I thought he would be present. So maybe the slides and a short clip is I should, but this is a slide that I have always dear to me. I'm grateful to Professor Carter and ACNS for their invitation. I want to thank you all. I've been a fellow for JITA for years now. As this clip is going to go on, I want to show the story. Fujita has had tremendous people from the day one. In the helm is a wonderful history of success in making sure to spread the neurosurgical education throughout the world. Leading the helm now is Professor Kato as a world-renowned surgeon, educator, And to my understanding, out of these many years of partnering with Professor Kato, the world with practice neurosurgery is small for her. My recent idea and my suggestion here, we are in a small community of friends, some of us fellow Fujita, some of us colleagues to Fujita. I propose the Yoko Kato Honor Your Mentor Fund of Fujita Alumni Neurosurgical Education. Just bear with me, one more slide that comes out of it. This is a recent paper that has been published at the WFNS journal, and I'm very happy to see that the numbers of fellow wonderful image. This is the birth of Asian Congress of Neurosurgery. Now, here are the numbers that I wanted to show. This is some great numbers that I'm happy to read. Fellows that have traveled from around the world to visit Fujita, irrelevant of the time, 1 month, 6 months, they have been there. What I mean by that is success is a teamwork, and I'm part of that team, and I'm very grateful to have been there and having those mentors guiding me. So thank you, and I very much wish you would join me into the initiative to honor our mentor today, Yoko Kato. This is a project that's going to be running for some time. Thank you to all of you. A late Merry Christmas wishes to all of you for those who celebrate. Happy holiday season, and most of all, a better, happier, and healthier 2022 for all of us. Thank you. That would be my talk.
Sir, please, if you share the slides with us, we will be very happy. You don't mind to share this with us. I mean the slides.
I would be grateful to share the slides at the end of the talk. I will email you the slides.
Thank you very much, Professor. That was an excellent talk, encompassing all the aspects of traumatic brain injury, right from history, management, and few personal cases, and at the end, your experience of all the mentors you had. The floor is open for the discussion. Any questions from the panelists? Dr. Chen, Dr. E, and Dr. Rihanna. Dr. Fawad Pirzad has already just joined us. Hello, Professor Fawad.
Hello, thank you. Thank you very much. Hello, good day for everyone. Thank you very much. Hello, thank you, Professor Arion Musabelio, for excellent presentation. It was very excellent and but good learning and teaching points. It was good for young neurosurgeons, and we welcome you for discussion with us. You know, in Afghanistan, we have a lot of neurotrauma cases, especially traumatic brain injury. We have a lot of cases, unfortunately, and this is growing up, and but limited resources in Afghanistan. Thank you, Professor Yoko Kato and Professor Sachin, for supporting Afghanistan every time. And as I mentioned before, that's the French neurosurgeons established neurosurgery in Afghanistan. We remember them, and also unfortunately in Afghanistan, we still use explorative craniotomy, Professor Arion. We use, because in government hospital, we haven't CT scan, and for this reason, we sometimes in emergency cases, we do explorative craniotomy. And unfortunately, our ICU for neuro care is not so good and so equipped for this. Even we operated on patients for not good take care of them. That's our outcome is not good. And in the future, we will have an international conference, and we will explain our situation and our experience about trauma, especially traumatic brain injury and unfortunately wall injury. We will share our experience for you and give your advice for take caring of our patients. Thank you, Dr. Sachin, and sorry for be late, and Professor Arion. It was really nice presentation. Thank you very much. Thank you, Professor Katu, and all colleagues that you are supporting Afghanistan through sharing your experience and knowledge with our young colleagues. Thank you very much.
Thank you. Thank you very much, Professor Pirzad. I'm sorry, it was my mistake to for the error in the time which I informed you. I'm so sorry. Professor Arion, you want to respond to him?
I wanted, it goes to say that those talks are very important. I work and study in a country where technology is at the top. I've been a fellow at Fujita in Japan where technology is at the top. But I must say I admire what you do. I've seen from the outside, and that's not a lot. So I thank you very much for bringing up the issue that you are bringing and putting together your work, and that's going to be published. I was not aware of the level of care of neurosurgery in Afghanistan until recently, when a work that has been done by Professor Kado and Mohammed Aziz Ali Sultan. Originally, I hear he's originally from Afghanistan, currently practicing in Boston, a very famous vascular surgeon. Never met him, but I watched him as he was talking about the work of his visit in Afghanistan. I think there is more to learn from what you do than what can we show. And I mean that what we show is practice of care and standard under the current higher standard of care in countries like Canada, like US, like Japan, but that's not the case in Afghanistan. And I wanted to point out throughout my slides. Thank you. So thank you very much. And I look forward to reading your work. Please do share that with us, please.
Okay. Thank you very much, Professor Arion, for your nice work. Yeah, we will share inshallah.
Thank you. Thank you very much, Professor Pirzad. May I request Professor Federico Sale to make some comments about the traumatic brain injury, especially in Uruguay, and about the presentation of Professor Arion, please.
Yes. So thank you, Dr. Arion, for your talk. I really liked it. And here in Uruguay, we also have many cases of traumatic brain injury, mostly car accidents and motorbike accidents, because falls are pretty common in older people, of course. But I was thinking that sometimes in low-income countries, we don't have available beds in intensive care, and sometimes we cannot perform ICP monitoring from the beginning. So usually, or sometimes we have to perform primary decompressive craniectomies. So I wanted to ask you, what do you think about primary and secondary decompressive craniectomy, and do you think it's a useful tool? Should we do should we replace the bone flap if you have like a subdural hematoma in a young patient and remove it from the beginning, or just put it back, do ICP monitoring? So what's the usefulness of primary craniectomy for you? And also a second question, do you have any experience with biomarkers? Because we are starting to measure neurofilaments and cognitive impairment in the long term and sequelae. So maybe you can talk a little bit about that also.
Dr. Sade, good morning there to you in Uruguay. I had a slide put specifically from a colleague of yours, a friend of mine, Dr. Gonzalo, Roberto Gonzalo, right? He's from Uruguay, right?
Yes. Mm-hmm.
I don't know if you know him in person, but he published not long ago a wonderful paper on the history of traumatic brain injury. I've had the pleasure to meet Roberto Gonzalo. Thank you for asking me your questions. I put the slide in purpose as if I knew that a colleague from Uruguay would be attending, so thanks. Challenging questions. I would come up with the first one, and I'll start with the history, as I was presenting a case of decompressive craniotomy when I was visiting Salzburg, and there was a team of very renowned team of world-renowned neurosurgeons from Weill Cornell in New York. Now, when I say renowned, I do believe you have heard of Michael Koplik. This is a very famous functional neurosurgeon. And as I was presenting the case, Michael asked me the same question. When would you perform decompressive craniectomy? And then when would you do the plastic? By then, I must be honest, my information was limited. I was fresh out of my fellowship in Japan. We haven't collected all the data. But I think I have not necessarily the best answer, but I have a better answer today. What we did, and actually I must thank Professor Kato, we went back to work. You know what? When you have a great mentor, and Kato has been one of those special mentors to me, she pushes you out of your comfort zone, and she tells you, you know what? We are good at this, but we should do more. So I studied, actually, we did study tissue to tell us when to do it. So my clinical judgment is very simple. Clinic and ICP monitoring. In most of the cases, ICP monitoring goes hand to hand with the clinic. And why do I want to point out ICP monitoring? I will let Dr. Ahmad Fawad Pirzad speak for Afghanistan, but there are countries that cannot perform ICP monitoring. And I mean, technology is not everywhere. So clinic tells us, the earlier you perform, if you were to decide that you will need to perform a craniotomy, the better it is. This is my experience, not necessarily to be followed. I attached the paper we had published. Actually, it's a book chapter we had that done on malignant stroke, and the results were wonderful. The earlier it comes. Now, there was a published paper at both. They were timing what would take and when should we perform decompressive, and that was published in the Journal of Neurosurgery. I may even bring that paper to you because I read it recently, and they said early, later, and then later. I would say early. The reason I would say early is because every second is brain. This famous saying has captured the minds not only of neurosurgeons but throughout the world, many scientists. And when it comes to that, every second we delay what procedure needs to be done, and in this case, decompressive craniotomy, we lose brain tissue. And every time we lose brain tissue, that does not come back anymore. And if we lose brain tissue, it comes to the cost of going to increase more the cranial pressure. And every time we have increasing cranial pressure, the outcome of decompressive craniotomy is not better, but is worse. So I was a little longer in answering the question, but I would say the earlier the better when clinical decision making is for that to be conducted. So I hope to have answered that question to you, or I should say better, that what I would do if it was for me. And I want to point out something else from Dr. Ahmad Fawad Pirzad. Yes, in my country, there are times that we have had, and I mean that back home in Albania, might be even the case in Uruguay, not necessarily in major centers in Uruguay, but we have to do opening trephine holes just to see if there is blood or not, because we cannot conduct back then CT scanning and have an idea of what was going on with the patient. Going back to your second question, you have come to a field that I'm very interested, not necessarily brain markers circulating in the brain, but I have to point out two things. As I was interested to research metastasis, and in this case, metastatic brain tumors, I've come to read many papers, some of these wonderful papers coming out of the University of Toronto, telling us that if we were to study certain and specific markers circulating in the blood, we would have a better knowledge of what's going on in the brain. And that's true. It comes out for the tumors because there is either RNA genomic material circulating or DNA genomic material circulating, and it tells us a lot. Will I use it? I would use it not necessarily for the first phase of treatment, if I am to answer your question, and for the clinical judgment of what do I need to do now, but I would use it for the follow-up of my patients. Is it costly? Not necessarily in US. I'm not sure how that goes in your country. Would I recommend to others? Yes, if they have the modality to follow. And if they are able to financially support that, it's costly. And it tells you a lot, it does. Is that relevant information? It is. It is helpful for clinical decision making and follow up and recovery period of your patient. Yes, yes, it tells you a lot. Why? Because there are cases when we do not see necessarily with imaging, and that comes with MRI as well, brain tissue damaged, but we see clinical evidence that there is damage following our trauma. So would we use clinical markers by then? Yes. Because when we see something is evident on your imaging, then use of clinical markers either is going to tell you not much more of what you see and what you have judged on your clinical management, rather than when we don't see something. Is it helpful? Yes. Is it costly? Yes. It depends on what you want to do. For research, it is wonderful. It is a wonderful work. And if you are one of those researchers conducting work in that area, I commend you. And I would very much like to read your work. Please, if you would share your email, then I will forward you after later in the chat my email, and I would read your work. But at the same time, let me extend my answer to your question, and I do apologize for taking this long. Has it been helpful in the field of cancer biology? Not so much so. We have been studying genomic materials from tumors, primary or secondary tumors. Is it helping? Yes, it is very helpful, but to what extent, that's going to be another topic. But in the case of traumatic brain injury, I would encourage use of it if that's financially doable for the clinic, and if that's to follow a patient after the first clinical assessment and surgery, not necessarily to have a decision made for the surgery. That goes to the first imaging.
Thank you, Professor, for an interactive discussion, and thank you, Professor Federico Salli, for asking those questions. Any other questions from the panelists or delegates? Dr. Shui from Myanmar, you want to ask anything?
Okay, thank you. And these are very wonderful lectures, and because in Myanmar, we have to encounter a lot of kids like traumatic brain injuries. So this is a very interesting, and we use a lot of decompressive craniotomy at the times. And luckily that we can perform the intracranial monitoring, ICP monitoring, but not every case. So, and recently, actually, we have a plan that to involve in that global neurosurgery study. But unfortunately, because of the current conditions, we cannot continue that. You cannot involve in that study. I would like to know one thing is, how about the traumatic brain injury in children, and like in your experience about the outcomes and the decompressive craniotomy? I think the children has a more better outcome than the adult person. How do you think?
I would give you this name is Dr. Schwab out of Germany. He has been conducting wonderful work, and I've read out of his work so much so that, but not necessarily decompression in traumatic brain injuries. Mm-hmm. Now, using traumatic brain injury as reference has been the fundamentals of working into stroke to perform decompressive craniotomies in malignant stroke. I would recommend it in children, and that's on clinical decision making to be made for each cases. With the results we have seen are not outstanding because my experience is limited, but what I've read out there tells us that if we were to consider decompressive craniectomy, and I need to tell you this is a wonderful experience that I've learned, that is not relevant of the side, because even when we cannot tell if that's a right dominant or a left dominant hemisphere, you still need to follow what the current indication is. If you have an increase in intracranial pressure, and the decision is for you to perform removal of the bone, I would suggest and I would encourage you do that. You do that with a large flap of dura removed as well, because it's very, very helpful. I see benefits out of it. Yes. Does the age make a difference? Not necessarily. You are saying the kids might come better out of it than the adults. I would say that all come with the mechanism of injury. It is hard to cluster those patients because the mechanisms of trauma differ, but the outcomes are outstanding if when we decide to perform the craniectomy is done right. Now, you remove the bone and everything goes fine. Usually, the most resilient cases are pediatric cases. The brain is still developing. But when do you put back the bone? And I hope Dr. Saleh, I see him being present, and I wanted to add something to the question he asked. And it goes back to some research we have done. You can put back the bone performing the craniectomy following decompression, irrelevant if that's traumatic brain injury or malignant stroke, based on what parameters. My experience has been clinic. The patient is free, the skin flap is free of infection, and the patient in general does not have infection out of any other organs or sources in the body. And within 1 month, we have been using MRI with very good results to see tissue changes in the demarcation zone of where is vital and non-vital brain tissue. And if that turns for us on what we signal that brain part is dead, there is no more surrounding edema. And usually this happens in between 4 to 6 weeks following malignant stroke or traumatic brain injury that has not been complicated with infection. Within that time, we find it the perfect time to put back the plastic. Then you decide to use the same bone from the patient that you removed early, or you put a plastic flap coming out of today's technology. That's up to you. But in between 4 to 6 weeks was a period that we judged to be the best one based on pathological findings. When I say pathological findings, we use tissue studied just to find out that there is no longer changes out of about 4 to 6 weeks that it's going to produce edema and eventually increase the pressure within the skull for us to have made the wrong decision to put back the bone. So yes, we would do that in children, we would do that left and right, and we would do that in adults when needed. Age is not a limit anymore. As it goes to say, in the vascular pathology, we used to have a cutoff that 7 millimeters is a reason for you to sound judgment, clip the aneurysm. That's no longer the case. Clinic tells you subarachnoid case of hemorrhagic, even if that's a smaller aneurysm, you need either to treat endovascularly, depending on the region, or you clip it. That's the case with trauma. That's the case with stroke. You see increased intracranial pressure that is not responding within the first 24 hours, or when it's giving you signs of compromising brainstem, that's the right time for you to do decompressive craniotomy. The sooner, the better. The age is not the problem. And thank you very much for asking the question.
I have one more question. And when you perform a decompressive craniotomies, and did you perform decompression alone or together with the cystinostomy?
I have not done it. I wish Dr. Yepcherian was here. He is a fellow of Fujita. Dr. Yepcherian speaks highly of the procedure. I have not done it. Anatomically, it is sounded. Surgically, it is possible. My experience, I still believe that the steps we follow to our judgment seem to be enough. Have you performed cystinostomy on your experience? I would like to ask you.
Yeah, never.
Never.
Yes.
As I mentioned, Dr. Yepcherian, a wonderful friend of mine and a great surgeon from Nepal, he has advocated for that. Does it make much of a difference? Not necessarily to what I've seen. And I try to be very curious in what I read. And when I say curious, I try then to follow, if possible, do some research work on my end. The research work I conduct might be limited because not all resources can be used for everything you want to research, but decompression has been sufficiently helpful in what we have done. If it comes to perform a cysternostomy, I wish Iep was here to answer that question, but that's not my case. So I'm sorry if I'm saying no to that at this time. Sorry about it.
Okay, thank you.
Thank you very much for the interaction. We can
I
take
knew.
one final.
My apologies, Sachin. I don't know why, but I had the feeling that question would come out of the cysternostomy.
It's become the point of debate recently. What I've seen, there are two groups of trauma surgeons. One is those surgeons who do cysternostomy, and those who do not do cysternostomy. And those who do cysternostomy, they are sort of being, very debatable and very critical about those who do not do cysternostomy. So I don't know how cysternostomy is going to take its course in future, but I don't know. What I believe is it's not indicated in each and every surgery. You have to be case selective for cysternostomy. There are certain cases where it will definitely be useful than doing just a decompression. What's your take on it, Professor? Maybe a last comment on it.
I'm the guy on the spot today, so I should answer this. If we were to measure volumes of two sets of volumes, the overall changes in volume following trauma is not necessarily that major in the first couple of hours, unless there is a volume of brain matter damaged. Would it make any changes when you perform cysternostomy? I haven't seen much of the benefit that would come out of it. My apologies when I say that, because it's blunt and out front. Most of the volume of CSF remains above that, not under that. And when you have to perform that, are you giving way to moving a volume of CSF to where? To a larger compartment? Not necessarily a larger compartment. That's how I see it. And when it comes to when should be done, if it comes to the point of craniectomy, the slide that I showed from a work that we published earlier, enough must be enough when it comes to you seeing changes in ICP decreasing right after you remove the bone. And then when you open a larger part of the dura, and the distinction in between those steps is huge, is enormous when it comes to the benefits that you expect. Is that gonna happen in every single case that you see out there? No. Then you come into the place of thinking with yourself. Should I perform a cysternostomy? Maybe, but I must be open that that's not my experience. So yes, I like debates, and I'm very open to see when it comes again into the floor, what are the guys that are using it saying about it. So I'm sorry we don't have any of those today here. But just to go out to the point of asking Dr. Shuigi, if I'm pronouncing your name right, is this under the current conditions of, and this should go to Dr. Ahmad Fawad Pirzad, this is not necessarily a procedure that you would perform everywhere. Not necessarily a procedure that you have hands-on instrumentation to follow every single step. I'm not sure, everybody should speak for themselves. But if I am to learn trauma, I would study trauma in the way it is studied in North America, but I would very much love to practice trauma in developing countries. That's where you are challenged the most. I'm not sure if you would consider the practice in Myanmar of the developing country, but I know the difficulties. I've learned something of the difficulties that Dr. Ahmad Fawad Pirzad is facing in Afghanistan. And that's when you have to make decisions based on what you have on your hands. Can you perform it everywhere in India, Sachin?
So major problem for doing the cystonostomy is having two things. One is good high definition microscope and micro instruments. So only those places, I would say a tier 3 cities, the metro cities, can perform the cystonostomy. But otherwise, the tier 2 cities where, some places the microscope is available, but not a great standard, or microscope is not available, or micro instruments are not available. I think the most of the work is just still decompressive craniotomy. Only few centers and few surgeons will do cystonostomy. So we have very diverse situation in India.
I think so.
I wouldn't...
also, sorry?
No, please. My apologies for interrupting, but please continue, doctor.
I think so, because in Myanmar, the microscopic surgery is very limited. So in our emergency rooms is very busy. Like we have to operate 6 or 7, sometimes like 9 cases, emergency operation, the brain surgery. So to perform the cystonostomy is very difficult condition, because we don't have microscope and good microscope in our emergency room. We do have for the elective surgery and for tumor surgery, but for the emergency, the traumatic injury case is difficult to perform. So we cannot perform up to now in that cystonostomy in that emergency case. So we only perform if we need decompressive craniotomy alone. So I also would like to know that difference. How about the outcomes, the good outcomes, or the same like this?
The outcome, please come again. What is that?
Yes. Sorry. So I also would like to know the outcomes between these two procedures, like decompressive craniotomy or cystonostomy alone, or decompressive craniotomy plus cystonostomy. I also don't know.
Well, if I am allowed, and I don't know how much time do we have at hand, Session, you can interrupt me at any time and tell me that the time is up, but let me bring you a case of experience that I've had when I was a resident back home in Albania. I used to practice under the mentorship of the deputy chair, a wonderful gentleman who taught me many things in neurosurgery, but above all told me how to care for your patient. Remember, we had a case of mastoid infection who followed with brain abscess, and we were not any better instrumentation compared with most of the developing countries. So we had to follow clinical judgment just to find where the abscess would be. We opened not necessarily a big hole, but what we thought would be enough for us to go through. I'm going to bring this to the point of what you are saying. And once we opened that not big hole, about 1 to 2 centimeters wide, the brain shifted. When you do cystonostomy under the conditions of increased intracranial pressure, the brain is constantly shifting. Unless you have the tools in your hand, the anatomy is not going to remain the same during the increased intracranial pressure. So I just pointed out a case with an abscess. We haven't reached the abscess yet, but I realized right up front that the brain was shifting as we made a way for, once we tripped into and they removed the part of the bone, the brain switched from its normal state with the abscess to a different one. What I want to say is that if you have the tools, by all means, you perform the cystonostomy. Now, let me bring you an image that I was searching right away, if I'm allowed to share a screen. I just wanted to point out this with you, and this is going to be my screen. This is not necessarily the best image, but maybe it's not letting me open right now. I need to get access in, but can you see what I can? Is it possible for you guys to see? That's wonderful.
Yes.
That's all what I wanted to show. You can perform that with a very small hole, but you know what you're doing, not under the cases of trauma, not under the pressure of emergency. It does require a steady hand. Yes, it does require a steady hand, but I know that you will be practicing it, and I know that you know the ways in and out when you do it, and when you use your endoscope and when you use your microscope. But small holes that are going to give you much changes of pressure, not necessarily the case. To answer your question, there are not comparative studies in between the two, or to what I've read, in between cisternostomy alone. It is not easy to recruit patients under the conditions of trauma and have a decision made for them by the family, or an advanced decision. And I speak in US or in Canada or in Europe, when you need to make these decisions, to have patients recruited for you to choose which one is going to go to cisternostomy category and which one is going to decompressive craniectomy. As I mentioned out, the anatomy speaks volume. When you open the cistern, what volume is gonna be removed? It's what's coming out even before you open the cistern, and I mean the CSF. And what's going to be transferred from the superiorly to inferior of that level of the cistern? Not much. Would I do it? In very particular cases, case-to-case decisions are what I choose and decide and how I move forward. But guidelines, principles are very simple, and it favors more decompression than traumatic, than use of endoscopy for cisternostomy.
Thank you.
Thank you very much, Professor, for that great interaction. But I think I agree with you that cisternostomy is definitely one of the future for trauma neurosurgery. But what we do lack is the multi-center randomized control trial. I think Professor Raif Cherian is involved in that, and soon there'll be some publications which will give us some way out and some clarification about methodologies and indication and techniques. We'll take one last comment. I can see hand up by Professor Pirzad, and then we'll go to the next talk. Yes, Professor Pirzad, please.
Hello. Thank you, Dr. Yi and Professor Arion for your recommendation. We also don't do cisternostomy in Afghanistan because the brain edema and the high pressure of intracranial pressure, increased intracranial pressure, and it's difficult to find the cistern. And the other things we also haven't microscope to do microsurgery and micro instrument. For this reason, we agree with you, we only do in some cases decompressive craniotomy, and just I like ask you about durotomy. And at the end of operation, do you do duroplasty as well, or leave the dura open?
Both. I've learned both from Professor Caro. The looser it is, the better it is. As long as you can cover that part of the flap with the skin, not necessarily required for you to try to bring dura as closer as you can. That's the point. You want to leave the dura open. And I would like to ask, but that might be something they relate with the conditions of your country. What kind of plastic would you use under limited resources? And that's the challenge. So I would prefer to leave it as open as it is, because dura by itself is very stiff, is so stiff that you really need to open the dura to release pressure. Without that, that's not going to make much of a difference. I've seen those in cases of malignant stroke, and I've seen those in cases of trauma. It's a drastic change in decrease of intracranial pressure just when you open the dura. As long as the flap of the skin can be monitored and would not be a source of infection to the deeper areas and deeper anatomical structures, Dural covering and use of plastic, I would not recommend it for as long as you have pressure under control. And for an expert surgeon, I think I can learn more of you and your expertise when it comes to practice rather than the books, because what we see firsthand cannot be substituted by books. When you see the brain swelling coming out of your durotomy, you know that you are making the right decision. And when you see the pressure relieved right off the dura, once you open the dura, you know that the difference has been made. And if you can use, under the resources that you have, a loose plastic just to cover the part of the brain that is under tension, but to not impose pressure again back, that's fine. It's perfect. It is recommended. There is nothing wrong with it. I would not use anything specific. As long as I have something to use, I'm fine with it. I can use even fascia if it comes to be used, because when the time comes, I have to remove it and discard it, and there is nothing to be lost for the patient. And financially, there is no loss. When it comes to using plastic materials, whatever you favor, when it comes to the indication, the brain would tell you. I always use sound judgment that comes out of any clinic. Do we need to put a plastic? Not necessarily, if I can bring the skin together. And when it comes to plastic over the skin flap, that's another question, but not for every case. And I would not need to put a plastic on top.
Okay, thank you. Sometimes
Thank you.
use fascia, yes.
You
But,
do use fascia?
Sometimes, but sometimes we leave open, as you mentioned.
Before I transitioned to neurosurgery, the way we train in Albania was that we had to go through surgery. It was a wonderful experience. In all cases of trauma that I've learned, I used some memory that I had from practicing surgery. It is a very simple principle. When you do a fasciotomy, there is nothing that you put back to close the wound. Just leave it open. The only difference with the brain is that you cannot leave brain matter out in contact with air. So as long as the skin can cover it, I find it perfectly fine. And why do I say that? I'm reading some wonderful articles coming out, not of science of medicine, but coming out of archaeology. Craniectomy has been performed even earlier than all of us together lives. And it has been performed so successfully. And what did they do? They just put the skin back. And how did they occur? Well, archaeologists found out that if there was infection, the corners of the craniectomy would be chopped and bite like an insect bite in a fruit or in a leaf. But if that recovers fine without infection, you would see that the flap was put back to the right perfect position back then. And I mean Middle Ages, when they had no way of controlling infections. So as long as the wound is clean and we do not put any other infection, which is usually hospital related, I would prefer to do the same way you do, Dr. Perzadan. That would not change. If you are in Afghanistan and limited resources, if you are in Albania with some better resources, or if you are in North America, just control the wound from infection. No need for plastic, leave the door open. And that's what perfect indication for fasciotomy or durotomy are. So thank you for your comment.
Thank you. Thank you.
Thank you. Thank you very much for the great interaction. I think Professor Kuwayama, are you there? I think he had to leave, our next speaker, and I think he has left us. So if that is the case, I think we can go ahead with the our YNS presentation by Dr. Safi, Khyber Safi. Dr. Safi, are you there? Dr. Safi?
Hello,
Dr.
sir.
Yes,
hello, sir. How
excellent.
are
you? Yes, very good. May I just quickly introduce you? and then you can start your talk. Dr. Khaibar Iqbal Safi, he's a neurosurgeon at Rokan Private Hospital and lecturer neurosurgery at Nangarhar province of Afghanistan. And today he's going to present a short case about ventriculoperitoneal shunt and its complication. Dr. Khaibar, can you share your screen and start your presentation?
Okay, sir. Thank you very much, sir, for your nice introduction. My name is Dr. Khaibar Safi. I'm from Nangarhar province of Afghanistan. I'm really thankful to give me opportunity and to present my research on ventriculoperitoneal shunt complication, which is conducted in Nangarhar Regional Hospital from 2018 to 2019. It's just for be the part of this prestigious talking in screen first.
Yes, please go ahead, Dr. Khaibar.
Okay, sir. Okay, just give me a few seconds. I will make my internet okay. Then I will be in touch. Okay. Give me 2 minutes.
Dr. Khaibar, are you there? Dr. Khaibar, your slides are visible. You just have to do
sir.
a full screen.
Okay, sir. I think okay, it's okay now.
Yeah, it's perfect. You just have to do full screen.
Okay, sir. Let me do it first. Sorry, because it was the signal was a little bit not okay. So I think that's good. Okay. Thanks for your patience because I just take a while. My presentation is based on ventriculoperitoneal shunt complication. It was done in Nangarhar Regional Hospital, which is a government hospital, from 25th March 2018 to 16 March 2019. Today's session will be anatomy in ventricular system hydrocephalus, cause of hydrocephalus, clinic and finding of hydrocephalus, and also investigation. We are going to discuss on hydrocephalus patient, treatment of hydrocephalus, and also the main part, which is complication of VP shunt, and my research result in some of discussions. As you know, the hydrocephalus is obstruction of pathway of CSF, which is in the intracranial. So this is what diseases happen, or what pathologies happen. It's called hydrocephalus. It means massive water in the cephalus or in the brain. It's called hydrocephalus. There's a lot of causes of these hydrocephalus. We have foramen manual obstruction, cerebral aqueduct stenosis, daily water, cystis, arenal cherubim formations, some infections, which infection goes to foramen magenda and also obstruct the foramen magenda and Miloshka, and also it's caused ventriculomegaly, some neoplasms and also granulosynostosis. It's all come out with some hydrocephalus cases. Sphenobiophilia, folic acid deficiency, along with myelomeningocele or also meningocele, it's also can be cause of hydrocephalus. Obstructions of arachnoid villi and also can decrease the absorption of CSF and intracerebral structures, also can cause hydrocephalus. Also, a lot of cystis and posterior fossa, like tentorium cyst, cordyceps cisterna cyst. Also, there was some kind of hemorrhage, RBC blockage, the pathway of RBC, which cause hydrocephalus. Also, brain surgeries can also cause the hydrocephalus cases. We have some kind of clinical findings. We divide it on 3 sessions, which is primary clinical findings, secondary clinical findings, and also some spatial signs, symptoms for normal patient hydrocephalus. We have in primary findings, we have some irritable children, some irritable patients with headaches, patients with nausea, vomiting, ICP, elevation signs, enlarged heads, diastase cranial suture, especially for the small children. The secondary clinical findings is neck vein signs, patching, high pitching signs, also prominent veins, and also sensitive. Normal pressure hydrocephalus, we have guide disturbance people, dementia, and also urinary incontinence. And in Afghanistan, we are using some kind of X-rays for these kind of people, for this kind of patients, especially for the small babies with congenital hydrocephalus. Translamination test we are doing here in Afghanistan. Scalar ultrasound, which is very cheap, and also it's available in all sites, especially in rural areas. We are doing this kind of ultrasounds, and we will detect patient with hydrocephalus. In some advanced centers, we are performing some brain CT scans for finding the type of hydrocephalus, especially for communicating and non-communicating types. And for some malignant cases, we are going to advise MRIs, especially for posterior fossa lesions and for posterior fossa tumors, or maybe some for ICH, or maybe subarachnoid hemorrhoids. So for this stuff, this is the best examinations we are performing for people with hydrocephalus. We are dividing the treatment in 2 sectors, which is the conservative and another is surgery. The conservative aims, or maybe the surgery aim, is to decrease CSF separations and also regulation of CSF through the brain, and also diversion of CSF pathways. This is the main objective of our treatment. For these cases, we are using furosemide 1 mg per kg per day for the small babies, or maybe for the elders, and also acetylzolamides 25 mg up to 100 mg per kg per day. If the patient is not performed or not recovered with these conservative staffs, then we are performing lumbar punctures, escape for the traumatic brain injuries, which cause herniation syndrome, especially tentorium herniation, the escape for the massive hydrocephalus, or for the other type of hydrocephalus, we are doing lumbar punctures. External drainage also for the massive hydrocephalus patients, which also for those patients who cannot afford the surgery or cannot afford the anesthesias or these things. So for these patients, we are doing only the external drainage. And also ventriculostomy, we are not able to do it here in Afghanistan because of it's macroscopic procedures, and also we are run of these steps. Shunts, we are often using these things here in Afghanistan, especially in our hospital. The best shunts we are using here is a silicone shunt, which one reservoir in the middle, in what is the outer parts, and another is the inner part. The inner part is going to the brain. It's a plastic silicone substance, and another part is a little lengthy, which is 90 centimeters. We are connecting a reservoir to the abdominal cavity for passing the C-sieves. We have only 5 types of these shunts. The most important one is ventricular peritoneal shunt we are using here in Afghanistan, especially in Nangarhar Regional Hospital. The other types are ventricular atrium shunt, ventricular pleural shunt, ventricular gallbladder shunts. Our lumbar peritoneal shunts, we are not going to use these styles because of the complications, especially these are should be done with the high equipment places, especially with the guide of fluoroscope or with the guide of some important or advanced instruments. In 3 points, we are going to put the ventricular peritoneal cannula or ventricular cannulation. Right in the frontal horn, 2 and 3 centimeters from the midline, we are going to make a line with a papular line with 10 centimeter anterior to the corneal suture. We are going to do one hole which is called Toker point. This we are using these kind of techniques here. Another is Keen's point, which is in trigon area, 2 and 5 centimeters to 3 centimeters posterior to superior pinea. We are going to do a small incision. Through this incision, we are guiding the cannula intraventricular, then we will guide it to intra-abdominal. Another is to occipital regions, occipital horns. We are going to do an incision 6 to 5 centimeters to the midlines, then right to 3 centimeters to laterally. We are going to make it shunts for especially for occipital. Important complications we are going to face: obstruction, another is shunt infection, proximal part infections, distal part infections, shunt malfunction, shunt overdrainage, chronic synostosis, Caesar, C-sif, ascites, pseudocyst of abdomen, and also skin reactions, shunt distal part, outing from anus area, which is a rare complication. And the new complication I found in my research, I had one patient, the shunt distal parts came out from his mouth while he was a small baby, like 3 years old. We put shunt for him maybe 1 year back when he came with the ICP elevations, and then we saw there's a white silicone plastic tube coming from his mouth. Then we were shocked. We didn't hear this in our books and maybe in practical areas. So this is the rare complication cases. I found it in my research of 1 year. And also some blindness because of compression of cranial nerve 3, 4, and 6. These are the complications we found. These are the actual pictures. This is the anterior, maybe it's the proximal part. This is the proximal part, and this is the distal part, infections. And also this is the reactional fluids from the proximal part of the ventriculoperitoneal shunt. This is the shunt of that baby, which has come out from his mouth. These are the obstructive shunts we are detecting in that study. And this is also the mechanical obstruction. The research we done for the ventriculoperitoneal shunt complication, it's descriptive studies, and also we detect the patients we detecting the cases related to age, sex, locations, and also type of complication. The total number of ventriculoperitoneal shunt procedure was 109, which is our inclusive criteria, which makes our inclusive criteria as perfect. It was 38. These 38 patients are all congenital hydrocephalus patients. The traumatic hydrocephalus patient was exclusive. The research found that we found from the research there was 20 patient was male, which is, and also 18 patient was female. From 1 day to 1 month, there was only 2 patients. And from 2 months to 2 years, there was a lot. The reason of why it's a lot, because the most people from Afghanistan living in rural areas, they didn't know how to protect the ventriculoperitoneal shunt. Also, they didn't know how to manage it. And also from when it start the complication in the rural area, we don't have the neurosurgeons to take care of these patients. So therefore, the most complication cases are found in the age of 2 months and also in the age of 2 years. We found 6 patients with the age of 3 years between the age of 17, below 14, sorry. The most complication found was from Nangarhar province. Because Nangarhar is in the middle, we are near, and also the hospital is in Nangarhar. So that's therefore we are facing with a lot of people from Nangarhar province. We found one complicated patient from Kabul. Maybe they will just travel here to Jalalabad or to Nangarhar. We just found this patient also. We found only 4 patients from Kunar province, and also we found only few patients from Nuristan and Laghman province also. The most complicated cases we found was abdominal pseudocysts, and also it's in the top, and also skin reactions. 2 patients, 8 patients with shunt upper and lower reservoir infections, 6 patients with shunts lower infections, and also there was 2 patients with disconnected shunts. Also, we found 1 patient with extrusions from his mouth. These are the results of my study. We have categories of high, moderate, and mild. The high complication group of this study was 2 months up to 2 years old patients. The moderate was 3 years old below of 17 years old. And the mild research population was 1 month of patient with the 1 month of year. Complication The highest complication we found, it was pseudocyst. The second one, it was VP shunt upper in lower part infection, VP shunt lower in liver part infections, VP shunt reservoir infection, and VP shunt lower part obstruction. These are the highest complication we found. The moderate complication we found, it was shunt disconnection and also the skin reaction. Uh, and also fever we found in few patients. And also there were rare cases, there was a rare case of shunt extrusion from his mouth. This was the short presentation. Because of the lack of time, I didn't prepare well. I'm apologize for that. If you have any questions, I'm here.
Thank you very much, Dr. Khaiber, for wonderful presentation about your study about shunt complications in Afghanistan at your institute. May I request Professor Irion to make some comment about shunt complication, especially ventriculoperitoneal shunt complication, and maybe some tricks for the young neurosurgeon to avoid this complication.
Sashi, thank you very much for asking me to follow up, but I want to start with something else. I just want to check first. Dr. Kabir, am I pronouncing your name right? Kabir? You're muted.
It's Kyber.
Kyber.
Yeah.
I thank you so very much for your work. I'm not sure about you, but my experience is attending several seminars.
I'm sorry to interrupt, Dr. Iron. Can you please bring your microphone close to your mouth? It's up there.
Is it better now? My apologies,
better.
Sincere apologies. More often we see results out of success, but what it is for us to learn is those that you presented, and I thank you very much for being honest in your work. I don't see you often, but I admire great neurosurgeons who come out to show what problems have come out of their work, and I want to remind us how challenging, what a devastating word might have been out of many years' experience of vascular surgery for Professor Charles Drake. However, he was always honest to present his cases that were the worst, not the best. And that's how we learned basilar tip surgery. That's how we learned basilar artery surgery. So thank you very much. In regard with my experience, that I've had back in Albania, not much difference. If I am to go back and see the statistics of work that we have been conducting, for the record, we would follow the same procedures that you would do. We do the peritoneal shunt almost exclusively. There are centers under limited guidance and specific indications that would follow other ways of shunting, but the lasting and the most successful shunt ever researched and published, that's the peritoneal shunt. I see you had complications both proximal and distal, and we have had those. More common for us, our experience has been with distal ones. We use the same quality of products, which is the silicone ones. It might be produced by a different company, but relevant to that, we use this almost the same. And when I say almost the same, there might be the difference. I'm not sure what would be the reasons of the frequency of the complications you have. The range of patients we have had does not differ, is the same. The reason for infection in cases that we have seen almost unique within the first month, And then the following would be not necessarily the same with the first month of life. So the first month of life, 3 very common pathogens do infect the brain parenchyma and the brain, the meningia, but following that is a very different pathogen. My experiences are not much better when it comes to what I remember from Albania, and it usually relate with the resources that you have at hand. So I'm not sure I would share any better lecture than the wonderful one that Dr. Khyber shared with us, but thank you for asking, Sachin.
But thank you very much, Professor. Is Dr. Federico there in the panelist, or not sure whether he has left? Professor Fawad Pirzad, maybe you want to make any comments about the shunt complication and about the presentation of our young doctor, Dr. Khyber.
Okay, thank you very much. Salam and Tashakkur. Dear Manana, Dr. Khyber Iqbal Safi. Thank you very much, Dr. Khyber Iqbal Safi. We're proud of you. That's very nice presentation and it was useful. And as Dr. Khyber Iqbal Safi mentioned, this is a unicenter. It was one center experience and not all over the Afghanistan experience. And we have difficulties also with pediatric neurosurgeon. We have a pediatric neurosurgeon, and all cases of shunting are almost doing by pediatric surgeons. And the other things, that's the quality of products. That's the products coming from abroad to Afghanistan. Sometimes it's not good quality. It's very cheap and the quality is not good. For this, the complication is, we have a lot of complication. The other things is the IP, infection prevention. It's very important, especially for shunting. And unfortunately, the IP in our hospitals not good, unfortunately. And this is for this reason we have a lot of complication, especially infectious complications. And the other things that Dr. Khyber Iqbal Safi mentioned about that the limiting of products, it's only the ventricular peritoneal shunt is available in market in Afghanistan, but we haven't lumboperitoneal shunt and programmable shunts in Afghanistan, unfortunately, and the other kind of shunts. That's mid-pressure shunt we have, it's available in Bazaar, and it's good for Afghanistan. It's good, for our poor people, and it's very helpful for them to doing and such operation in Afghanistan. It was good, and we hope in the future we make a plan for train pediatric neurosurgeon as well for Afghanistan, for every center in Afghanistan. And I proposed many times, you remembered about pediatric neurosurgeons. And we also interested in third ventriculostomy. Maybe it's also be another opportunity for reducing the complication of shunts. Thank you very much. Thank you, Professor Arion, for your nice comments, and thank you for Dr. Khyber Iqbal Safi. We're proud of you. Thank you.
Thank you, Dr. Pirzad. We can understand the problems about the logistics and about infrastructure. May I know the cost of this shunt which you are using in Afghanistan? How much does it cost there? in dollars?
It's sometimes maybe $100 or less, $50. It's dependent on the company. You know, it's very very cheap, and for this you know that's estimate and predict the quality.
Okay.
May I add some things, sir, in these sessions? Thank you very much once again for this nice opportunity that you gave us for the talking, and special thanks from our boss, Dr. Saib Pirzad, and also all members. Yes, the poor people of Afghanistan doesn't know the folic acid. You know, the main things are the folic acid deficiency, which is they have to take it, but in the rural areas, the mothers are not taking these supplements or these drugs. And also their iron deficiencies, their vitamins deficiencies. And people of Afghanistan, especially the rural areas, people are thinking, when the doctor put the shunts, it's done. But it's only this, it's not the solution, but it's only the way of the treatment. And then we saw a lot of people with bad reaction, with bad skin reactions. They are coming from medicines, probably they're not taking them, especially for the fever, for the post-operative cares. And also that Mr. Pirzad said that we had faced with the low quality products. In Afghanistan, we are using only the shunt made of Pakistan or maybe made of India. It's kind of Chopra shunts. The quality is not good enough for the treatment of people to stay for the long time. The good shunts are the American shunts. It's made on American, but it's a lot of, it costs a lot, maybe $250 per case. The shunts we are using, it's in low price, maybe $70 to $100 at all. Causes of the infections we are facing a lot with these cases. And the other things is they are the real numbers that we are showing. Maybe in some cases the people are hiding their infections rates, but we are not. We have to expose it. So that's all.
Thank you.
Yes, anybody has any comment? I can see Dr. Arian hand raised is there. Do you want to make any comment, Professor?
Actually, I wanted to congratulate the honesty of colleagues from Afghanistan. Yes, that's true. Publication is a world of intricate of intrications. Not many of us do publish the bad results. But if we have to learn, it's about both sides. I am very sorry to hear the current situation is like that in Afghanistan. I do believe Afghanistan is not the only country. But I have a feeling that Afghans have great surgeons to take care of them under the current conditions. And why do I say that? You know the epidemiology and you know the prevention ways of what to have to deal in Afghanistan. And if you are a surgeon that know medicine before surgery, you definitely are a great physician. And I mean it for both of you, for the president of the current president of the Afghan Society of Neurosurgery, and for you, it is my understanding that you practice in 2 different locations, not in the same hospital. Is that correct?
Yes.
And you both sharing stories of challenges. I have a very short experience to share. If I have learned the most, it has not been the centers of excellence for a short time, but has been the centers where actually there is no center to learn. Those have been the experience that I always remember. It is the case in my country. We have only one university clinic, one trauma center. The two are connected. But if you leave the capital, everything else is under you to take care and to come up with inventions for you to use to treat your patients. And I've learned a lot out of those experiences. I'm so grateful for you to share your work. And I trust that if you share both sides, the best and the worst of the work, there is much to learn than just showing how good things happen. Thank you. Thank you very much.
Thank you very much, sir. Thank you very much, sir, for your nice comments. And thank you very much for your enhancements. It's the real Mr. Pirzad is in the center of Afghanistan.
I think Dr. Khyber's network is.
That's
we are in the province. Yeah. We are in the East province of Afghanistan.
Yes, the other things, we also have a lot of other cases of hydrocephalus, and the cases that we also put VP shunts. And for this other cases, also we have complications and challenges as well.
Thank you, Professor Pirzad. No, I was just discussing with Professor Yoko Kato. I think from India, we basically use 3-4 kinds of shunt system. The basic one is Chabra, which even you are using at your places, as Dr. Khyber was mentioning. And in some cases, it is actually very good shunt. The little higher one is the GSL dome valve, which is little costly, but it is one of the best shunt system. And some lumboperitoneal shunt, which in India we have, the cost is quite less for us. I think we'll work together with ACNS and with Professor Yoko Kato, and we can work out to send few shunt systems there, so that it'll be from the ACNS. We can do that. Let's see how it goes. We'll discuss it in our executive board meeting also. Professor Yoko Kato, you want to say something?
Oh, thank you very much. It was a wonderful talk. And I think the shunt surgery is very fundamental one, but it's very important. I think not only the shunt system, but also maybe we can provide some the surgical technique, surgical procedure of the shunt. We can provide you from the ACNS the video series. We can send you. Thank you very much for congratulations for your talk.
Arigato gozaimasu.
Okay.
Thank you very much.
Okay, sir. Okay, sir.
Thank you. I think congenital hydrocephalus and few of the infectious hydrocephalus are one of the preventable causes of death. So, hydrocephalus is one of the very important. A lot of campaigning is happening for hydrocephalus. So, thank you, Professor Kato, for being generous to provide the help for shunt management and ventricular hydrocephalus management for Afghanistan. Now, anybody has?
Sorry, just you can ask the president of Afghanistan how we can transfer the shunt system, because some difficulty sometimes. So I think so you can ask him, please.
So, Professor Fawad Pirzad?
Yes. Yeah.
So how do we send it to Afghanistan, maybe from India, or how do you think it is possible?
Yeah, the recent days, that's the flights are continuing to Afghanistan. We can do it through India or through China, and also through Emirates, Dubai and Qatar. Nowadays the flights are going better, and we can do. And the good news is that the high-speed rail also reached to Kabul airports. Custom, and we will soon distribute the high-speed rails as well. Thank you. for your support, for your helping Afghanistan through supporting Afghanistan neurosurgery. Arigato.
Thank you. Thank you,
Okay.
Professor Pirzad. Congratulations for the high-speed drills has reached there. We are really happy for that hope. And we pray that you'll do more better neurosurgeries and better surgeries in Afghanistan with that.
Okay,
Professor Federico Saleh, are you there, Professor Federico?
Yes, I'm here.
That
was a very interesting talk and a very important subject, of course. What we try to do is, first of all, avoid VP shunts, especially in children. If we can perform endoscopy, we prefer it. Sometimes you just can't. And then, well, of course, surgical technique is very important. The length of the surgery is very important. You have to do it fast. And well, we also use, we change gloves very often, try not to touch the system. I mean, there are, of course, try not to touch the skin, and then with the same gloves touch the catheter. I mean, there are very simple tips that can help avoiding infections. But that was very interesting. Thank you.
Thank you very much, sir.
Thank you. Thank you very much, Professor. Anybody want to make any comment or any suggestion? Dr. Chen?
Yes. I remember when I worked as the pediatric neurosurgeon in Xinhua Hospital, my colleague also did the same research about the hydrocephalus, VP shunt infection, and broken. I think the reason and the percentage is also the same. With the same, we also find such cases. And the cases happen in clinical work, and the patient have to come back, especially for the catheter broken in the abdomen. It was emergency surgery in my memory. Okay, that's all. And regarding the trauma, the brain trauma injury, I want to introduce the situation in China. Firstly, thanks for all for your presentation. We learned a lot from your experience. And in China, we have special trauma team. They only do the brain trauma surgery, include ICU and the surgery. I belong to a neurology team. So, but in the first year, when we trained in clinic, we practice on the clinic for the trauma surgery and take care of the patient. But later we can choose different direction. To me, I choose the neuro-oncology. So in my memory, we also do the ICP monitoring in the ICU and the operation, such all. And I forgot the point I want to share. Yeah. So it's different talk to me.
Thank you. Thank you very much, Dr.
Thank
Chen. It's so nice to hear your voice and your active participation every time. Thank you very much.
Oh, yeah. I remember when I worked as a pediatric neurosurgeon, I also worked on duty in the emergency department, and we have many patients. The baby just fall down from the bed, and the patient's family took the kids to our hospital, check. So we always told their parent or family or guardians, watch the patient's neurological response for 6 to 12 hours after injury. We want to check the patient's neurological situation again and do the CT scan again to check if the delayed hemorrhage happened. In my memory, the delayed hemorrhage percentage is very low. Usually the baby are safe. They are safe to experience the trauma. I think the situation was not very severe. And in China, our government has a request the driver include electric motor and gas motor. The drivers must wear the helmet. Wear the helmet. So I think after the helmet policy performed, the TBI percentage comes to low. So it's very important to people driving on the road. Driving on the road, so it's very important to TBI, to prevent the TBI. Okay, thanks you all. I'm happy to join this webinar. Thank you and Happy New Year.
Thank you, Dr. Chen, for a wonderful comment. Anybody wants to make any comment or any question? Dr. Rihanna, I can see her. Dr. Natalia is there from Russia. Dr. Ashmat? Okay, if no comments, then we'll have a closure of this webinar. First of all, I would like to apologize on behalf of ACNS YNS committee for the absence of Professor Kuwayama, who was supposed to present a wonderful talk about the flow diverter. He is the director of the hospital and the Department of Endovascular Surgery there. But since he had an emergency case, he had to leave. So maybe next year is 2022. I'm preparing the calendar for 2022. And he's promised us that he'll have us with us for the presentation and interaction. I would thank Professor Irion K. Musabelu for wonderful presentation. I think it was very realistic presentation, including everything about the history, about the management, his personal touch, and a great interaction with all the participants, especially Dr. E from Myanmar and from Afghanistan, Professor Pirzad. And I congratulate Dr. Khyber for a wonderful presentation about bringing up that problem about hydrocephalus, and congratulations for the study and the research you're doing. Please continue doing it. I mean, the clinical and surgical work should be going, but by hand, the research should always be there. And that's what teaches us and gives us the feedback about what work we are doing and where we are lacking. Just for my personal experience, I would just give you two suggestions which were given to me by my boss, Dr. Balamurugan, who was also a fellow at Fujita and who's a student of Professor Yogo Kato. I think any shunt surgery should be the first surgery in the OT. It should never be a second or third surgery. It should always be the first surgery in the OT. And overnight, OT should be fumigated, just basic fumigation, and the first surgery makes a lot of changes. So everything is sterile, the shunt infections are less. And the tapping of the ventricle, it should be a first tap and it should be a non-bloody tap. Once there is a blood, the chances of blockages and infection increases. That's my personal experience, what I've learned from my teachers. Thank you everyone, all the panelists and everybody for being there together. May I request Professor Yoko Kato to say a few words, please.
So nothing to say now, but I think Professor Morris Shooks, he is a very nice, excellent, of course, the kind of the founder of the pediatric neurosurgery in the world. He is very strict for the shunt, the surgery, because there's some regulation of the number of the nurses, and also the timing of the open the shunt system. So everything that he stick to very precise surgical manner. So anyway, I think for the YNS, I think just you can do your best every day. We do not know in the future, so but I think every day accumulates all your future. I think so. That means is importance is to do your best every day, because Dr. Arion, he now is became a very high ranking of the neurosurgeon in Canada, but he when he came to us when he was young, so at the time that he was very beginners, but now he became a very big neurosurgeon. I think he is one of the role model of the neurosurgeon, I think. So, but I think please, you will have a very bright the new year. I think we'll see either in virtual or in person in next year. Thank you very much.
Thank you. Thank you, everyone. Before we leave, I just want to make very small and little premature announcement that May 2022, we're going to have one dedicated Congress, the first Congress for the young neurosurgeon. So it'll be a first World Young Neurosurgeon Congress. So where we've got a good outline of programs, a good hands-on workshop. I don't know how the time is going to fly towards the end of May. If possible, we'll try to arrange some cadaver workshop, at least in those countries where the possibility of traveling is allowed. If not, we'll try to have virtual cadaver workshop, which we are doing. Some virtual workshop about endovascular surgery, about bypass surgery, and certain change and a few special sessions about like challenges of neurosurgery in low and middle income countries, collaboration of all the YNS for different continents, research in neurosurgery, mentorship in neurosurgery, and advances in new technologies. And we're going to have 2 days dedicated YNS competition session. So I would request everyone to send off their research project. I would request Professor Dr. Khyber also to send his research study and have a platform. I think every young neurosurgeon should not only just practice doing the surgery, but have a practice of doing research and giving a talk on your research. So that way you learn from others researchers. When you go for the conferences, you see different researches happening, and you grow as a surgeon, as a researcher, and as a person also. So please send your CVs, and I invite you all for this World YNS Congress. So thank you very much, everyone. Is Dr. Khyber, I can see your hand raised. You want to say anything? You have to unmute yourself, Dr. Khyber.
Something based on your experience that you share with us. Yeah, in our hospital, it's a trauma center. Yeah, it's the reality. If you are on that day, we did elective surgeries in the separate room or maybe in the clean room, the rate of the infection is getting low. Yeah, it's true, sir. In that days, the load of the patients, load of the procedures was a lot. We detect some patients with the complications. You are absolutely right, sir. And it's true things. Inshallah, in upcoming procedures, we are following all these instructions that I heard today, and maybe we will come out with the good results, inshallah. Thank you very much, sir.
Thank you. Thank you very much, everyone. For those who are already celebrating Christmas, so happy Christmas, continue your celebration, and a happy new year. Have a wonderful new year. Hope the COVID ends. Plan your new plan, new strategies, especially all the young neurosurgeon. The future is in our hand. We should be more realistic, more futuristic, more innovative. So let's do it. Have a great plan. Have a great new year. Thank you very much.
Okay, thank you very much, sir. Thanks.
Thank you,
Happy
Professor
New
Arian.
Year. Thank you so
Thank you.
very much.
Happy New
I
Year.
look
Thank
you
forward
very
to
much.
May, hopefully
Yes.
meeting you in person.
We'll invite you, Professor. Definitely
course.
will invite you.
See you guys.
See you. Thank you.
you.
Thank you very
Thank
much.
you so much.
Bye.
Bye.
Thank you very much.
Bye.